Welcome, ladies and gentlemen. It's a great pleasure to have the opportunity to make this webinar today. May I tell you some things about my person? My name is Dr. Stefan Klinger. I'm a general dentist in Germany with a specialization in endodontics. And so we talk about endodontics today to be more specific about the use of ultrasonics in endodontic therapy. The duration of this webinar will about 60 minutes. Let us see the roadmap. So this roadmap shows you the way that we will go together this evening. First, I'd like to tell you a little bit of the theory of ultrasonics and its development for dentistry. It's only a short overview, but I don't want to bore you more as necessary. Then I will talk about ultrasonic devices and tips. There are so much different devices and tips on the market, but I will only mention that one I know or have experience with. At least I have prepared some video clips for you where you can see some cases with different applications of ultrasonics in endodontics. But what is ultrasonic? I'm sure that every one of you uses any kind of ultrasound devices in the office. Most of you will use it to remove calculus or as an add-on to periodontic therapy or for the cleaning of burrs or other dental instruments. And some of you might use it for minimal invasive preparation of small cavities for direct resin fillings. And others again use it for endodontic treatment or even for surgery. You can see the applications are various. In the 1950s, it was introduced in dentistry first for cavity preparations, but it never became very popular because high-speed handpieces were much more effective. And as you might know, even today the cavity preparation with sound devices like the Cavitation or today's SonicFlex system still can compete the use of handpieces, but it has its important place in microdentistry. When I had to choose between my handpiece and ultrasonic, I surely would quote for my handpiece and a burr. I tried it some years ago and in my hands it was not very effective. But what came next? A new application was found by Zimmer in 1955 and was improved by Johnson and Wilson in 1957. It became an important tool to remove calculus and dental plaque. At this time, the use of ultrasound in endodontics was introduced by Richman, but it was not until 1976 when Martin demonstrated its ability for endodontics. The term endosonics was introduced by Martin in Cunningham and was defined as the ultrasonic and synergistic system of root canal instrumentation and disinfection. At this time, nickel-titanium instruments were not yet available. Instead, K-files were used. But better we talk about ultrasound instead of ultrasonic. First, because it is a term used to describe sound energy with a frequency above the range of human hearing, which is about 20 kHz. The first ultrasound devices worked at a frequency about 25 kHz, but also there are systems that worked at a lower frequency, about 1 to 8 kHz, which are called sound systems instead of ultrasound systems. What you can see on this picture are nodes and antinodes which appear along the instrument when it is activated with ultrasound energy. In this example, it is used with a piezoelectric device. In the following folds, I will show you different devices that work with different sources of ultrasound or even with sound. Magnetostrictive systems like the Cavitation device converts electromagnetic energy into mechanical energy. Magnetostriction is defined as the deformation of ferromagnetic materials at the cause of magnetization. Thus, magnetostrictive metal strips are subjected to an alternating magnetic field, and this causes vibrations on the file. Instead of the older magnetostrictive systems, nowadays the piezoelectric principle is more common. The piezoelectric effect was discovered by Jacques and Pierre Curie in 1880. It describes the internal generation of an electric charge caused by mechanical deformation on certain solid materials like a crystal. You can realize this phenomenon when you use a piezo lighter. In fact, An ultrasonic device like the Piezomaster uses the reverse piezoelectric effect, where an electric charge causes a deformation of a crystal and thus causes vibrations on the file. Sound systems like the endoactivator or the sonic flex system work with electric power or with pressure to make the file oscillating. It works with less energy and a lower frequency as the ultrasound systems. This results in a lower production of heat and shear stress to the file. So let us summarize the devices. We can distinguish sound and ultrasound devices. The ultrasound devices where we can differentiate in magnetostrictive and piezoelectric systems. Sonic systems work with pressure or an electric-driven motor, produce less heat on the file, work with lower frequency and have an elliptical movement. The lower energy on the file produce less shear stress and thus less danger of a fracture. In addition to this, especially when used with uncoated plastic files, these systems produce less or not any damage on the canal walls. In endodontic therapy, they are mainly used for passive ultrasonic irrigation. Magnetostrictive systems produce more heat than sonic systems or piezoelectric systems and have a more elliptical or figure-8 movement. The energy produced on the file is less than that of piezoelectric systems. In endodontics, it can be used for passive ultrasonic irrigation or other applications. The piezoelectric devices work according to the reverse Piezoelectric Principle, produce less heat than the magnetostrictive systems and work with a back and forth movement, which is described to be more efficient for endodontic therapy. In addition, it is the appropriate device for surgery like apicotectomy. This finally leads us to the different tips which can be used with the devices. I will present the tips which I use normally or have experience with. These are the Pro Ultra tips from Dentsply, the Endosonal Files and the plastic tips from the Endoactivator. We can divide coated tips, uncoated tips, cutting files and plastic tips. Coated tips are good for troughing the pulp floor when you want to quick removal a calcified or irregular dentine or for removal of overhanging dentine. It's mostly used with high or moderate power depending on the diameter of the tip. These files produce a lot of heat while working on the dentine, so their use is recommended with water cooling. Uncoated nickel titanium tips are more likely to be used for passive ultrasonic irrigation or for removal of broken instruments or to remove remains of cement or resin. Although they are uncoated, it is recommended to use them without contact to the canal walls while doing a passive ultrasonic irrigation. Cutting files like the Endosonal Files are well suited for creating space between a broken instrument and the canal wall. This space is needed to remove the instrument with any kind of tube technique. Also, it can be used to vibrate out such fragments. It depends where the fragment is located. A very careful use is recommended because these files can produce ledges. Plastic files are used with sound systems. They are not coated and smoother, so it is unlikely that they produce any defect on the canal walls. They are used for passive ultrasonic irrigation. So let me summarize the applications in endodontics. For post-removal, location of hidden entrances, removal of calcifications and fragment removal. Magnetostrictive and piezoelectric systems are appropriate devices. For retrograde preparation and surgery, the piezoelectric systems are more suitable because of their back and forth movement. For passive ultrasonic irrigation, all systems are efficient. Let me finally just say some words to the passive ultrasonic irrigation. Two mechanisms are discussed in the literature to describe the cleaning effect of PUI: the acoustic streaming and the cavitation effect. The acoustic streaming. Several papers have shown that acoustic streaming or microstreaming is present while the irrigation of the canal. A pattern of nodes and antinodes arises along the length of a free oscillating file, which causes a fluid movement and thus shear stress on the canal walls. As a result of this shear stress, debris and bacteria will be removed from the walls. Cavitation can be divided in stable cavitation and transient cavitation, which depends on the amplitude with which the file vibrates. Higher amplitudes cause more transient cavitations. Both have in common the arise of cavitation bubbles, which first expand and then rapidly collapse, releasing a high amount of energy. This causes, as a result, a removal of debris from the canal wall. According to Young, acoustic streaming is the main mode of action, assuming the file can vibrate free in the canal. And if you did not feel asleep until this point, congratulations! And now we will have some fun and see some video cases next. One thing that is most important in dentistry is to have the right tools at the right time with the right purpose. So in this case, I knew that under that crown I will find a post that has to be removed. The patient was sent to me to retreat formerly performed root canal filling because a new crown was planned. Under such older crowns, I think it was more than 20 years old, you will find in most cases only a build-up made of Harvard cement. I always like to not remove a crown when I do a root canal and when the margins seem okay and when the radiograph doesn't show any leakage so far. If the crown has a leakage, I remove it of course and do a pre-endodontic build-up and a temporary crown instead. It has the advantage that the rubber dam clamps have a better retention, but you will have a different method perhaps. I always try to make the excess cavity as small as possible and only extend the excess when it is necessary. So you can see I try to drill very conservative into that crown. You can imagine that I was not happy as I found out that the whole build-up was made out of resin filling material. You can spot the post a bit, but the opening is way too small, so I had to massively extend its diameter. The post was entombed in resin, so the only way to remove it was to remove all the surrounding resin, but I had also to preserve as much of the post's body because it might be possible to only screw it out with a handle grip, but the truth was another, and as you will see a little bit later. So first I used some thicker diamond burrs to remove as much as resin quickly. The Muntz burrs were used because of their long shaft. I was able to have a better visually control where the burr works and how. The advantages of the Muntz burrs are their sharpness and stability. They stay sharp for a very long period, and you can remove dentine, resin, cement or whatever very quickly. Also, the different diameter are very helpful when it comes to very small and gentle preparations. A very thin needle-like diamond burr was very helpful to remove the resin out of the spaces in between the cross spaces of the post, as you can see here. You might be able to imagine how difficult it was to remove it because the patient had a very limited mouth opening. Maybe you can see it in the video. This burr was very helpful to clean up the spaces between the wings of this bore. So, and now you can see most of the resin has been removed. As you can see, fortunately the post seemed not to have been cemented with resin also, but with Harvard cement instead. This made it easier to destroy the cement gap with ultrasonic instrument, but we will see this in a second. But there are still remnants of resin in between the wings of the post, and the goal was to loosen the post to finally rotate it out of the canal, but the resin blocked any chance of rotation so far. More and more of the cement has been removed. As you can see, the dentine structures. I make this example a bit longer to watch to show you how difficult it is to specifically remove only the cement and the resin and not to touch the sound dentine too much. And now it's time to use ultrasonic tips to free the gaps from the cement and resin. This is a coated Pro Ultra tip from Dentsply that works best with a piezoelectric ultrasound device, but also a pressure-driven sound device like the Sonic Flex from Cavo, and with corresponding tips will work efficiently. You can see the power when you watch how small remnants of resin are destroyed and are vibrated out of the gaps. Normally it will have to be done with water cooling because this procedure produces heat to the post and to the surrounding dentine, but for demonstration I recorded the sequences without water cooling, so you have a better view. To reach deeper areas of the cement gap, very fine instruments have to be used for, so the Endosonal Files are very suitable for this. They are used with a so-called endo chuck, where they are chucked in. But be aware of the energy you operate with them, because they break very easily when they oscillate with too much energy and without contact to a solid material. When you want to use it for irrigation, then turn down the energy to 1/3 of the maximum. So some will say, why don't you screw it out, the post? Why don't you screw the post out with the corresponding handle? I have to say that I had not enough space between the crown and the post to place the handle properly, and this is more important to me. I did not want to deliver more stress to the dentine walls as necessary. With a handle you give a lot of power to the post, and the post will give it to the dentine. I didn't want to risk cracks or even a fracture because of being impatient. By the way, the most frequent failure in endodontic treatment is impatience. Whether it is when you search for canals or while you do your irrigation, always take your time you need to do your job well. But this is only a side note. Back to the case now. You can see how specifically I remove step after step the cement out of the gap between the post and the canal. Always trying to remove sound dentine and always trying to be as near on the post as possible. If you try to move the post now out, you will fail, because it is cemented so solid that it moves not a tiny little bit. The best way to cause a fracture is to use too much circular power now when a handle and with a handle, and then to try to screw it out. I cannot recommend this kind of technique in this case. There are others where this can be right way to remove a post safe and fast, but not here. Now another tip comes to action, which is actually uncoated. It has a broad tip and serves to deliver power to the post in order to destroy the cement gap in the deeper areas. This will lead to a high amount of heat, so water cooling is highly recommended. You can see how much power it gives to the post head and how the post vibrates. So in this case it is without water cooling to show you the power of this tip, but in a few seconds you will see that we will have the water cooling instead. Now you can see how the resin is flying out of the excess cavity, how much power this tip gives to the post, and you can imagine how much heat it will deliver to the post and at least to the tooth. Now we have water cooling. You can see how the post vibrates. That will destroy the connection between the post threads and the dentinal walls. With the time the post will lose its friction, but it also takes time and patience. Always with water cooling. Another try to lose this post. Okay. Now you can see it moves a little bit. Now you can see how the post gets loose, and you will notice a slight movement of it. It's near to removal. I now stop the water cooling to let you see the details better. It's loose and it will be turnable soon. Now you can see the movement, and it turns and turns around. Now the work is done. All we have to do is to take it out and start the retreatment. You can see that it is totally free of resin at the wings in the next picture. Yeah, totally free. It was a hard work, but worth the time because I have not caused any additional damage to the tooth. The next case is an example how stupid one can be. This is a nice example of what you should avoid to do. It is upper second molar where you can see the buccal and the palatal canal. The two canals that you can see confluent apically, and the palatal canal makes a sharp turn into the buccal canal. So far so good. The canals were treated so far with hand files and rotary files, and I just wanted to have a last finish of both canals with a file in reciprocation movement. In the buccal canal all was good and okay, but watch what happened when I put the rotating file into the palatal canal. It broke. It is always a bad feeling when you see the file comes out shorter as it should be. Here you can see the fragment which was located in the curvature to the buccal canal. With uncounted ultrasonic tips I tried to vibrate the already loose fragment out of the canal. I thought it will jump out quickly, but it didn't. Also I tried to give it a push from the buccal canal, but the only thing it did was moving around a little. Also, I tried a shorter tip, as you can see. This is the purple tip of the Pro Ultra series, but you can see nothing happens. So what is the solution of this problem? You can use the power of ultrasound to create a fluid movement that is strong enough to float the file fragment out of the canal. So I fluted the canals with sodium hypochlorite and gave power to the ultrasonic tip. And now watch what happened. The fragment came out easily. It was pushed out because of the pressure that was caused by the ultrasonic power. Now you can easily imagine the massive power that the ultrasound tip delivers to the sodium hypochlorite or any other fluid. Now here you can see the fragment in its full beauty, but certainly it is the better way to avoid any fractures. So I have learned another chapter in endodontics, and highly curved canals in the apical portion is a no-no for any rotation file in the future for me. But maybe in your hand this works better, but I cannot recommend it for sure. The next one is an example where you can see again the power of ultrasonics. It would have been a great advantage when I had a high-speed camera to show this more detailed. An ultrasonic tip is inserted in a canal which is fluted with sodium hypochlorite. Now watch the development of nodes and antinodes along the file. You have heard this a few minutes ago within my lecture about the theory of acoustic streaming, and now you can see it in real life. You have to try it at your next treatment. Gently pull out the tip out of the fluid and watch what happens. I tried to show it in slow motion, but the explosions are too fast for my possible frame rate of my camera. But I think you get the point, and you see the power. Imagine that power on the canal walls, and you can imagine the cleaning effect of ultrasonics while the irrigation. Nodes and antinodes, and now see how they explode. Bam! This is very amazing. Next is to show you the cavitation effect and the rise of bubbles in the canal. The canal was prepared with profile until 4006. The canal was fluted with sodium hypochlorite, and then an uncoated file was inserted in the canal and activated. Watch what happens here. The bubbles explode rapidly, but you can also see the airlock effect. Where greater bubbles arise, whether they are caused by the cavitation or by bringing in too much air while inserting the files, these regions are not going to be cleaned properly, because neither cavitation nor acoustic streaming will be delivered there. So moving the ultrasonic tip up and down is mandatory to destroy these stationary air bubbles, although also changing the fluid frequently helps a lot. But what happens when you use cutting file like the Endosonal File or a K file, where you apply the ultrasonic energy via the handle? If an ultrasonic tip has edges, the effects like the acoustic streaming or the cavitation effect will be more distinct than with uncoated tips. Along the edge there will be more turbulences, and I hope this picture will be branded in your brains. You can see how dangerous it is to use those files. Please note the development of ledges in the canal wall. With this procedure you have a great chance not to be able to reach the apex anymore, and you can see the handful doesn't have a chance to overcome this ledge. Next case is an upper second premolar. On the X-ray you can spot the uncommon anatomy of it and also the first premolar as well. The patient came because of pain after a filling that was made a few weeks before. And you can see the filling reaches the pulp floor already. It is most likely that this tooth is a multi-rooted and you have to search for more than one canal. Also, it is most likely that it has the anatomy of a molar with a palatal and 2 buccal canals. Here you can see the palatal canal and the distobuccal canal, very good. A bit covered by the palatal canal, you can see the mesiobuccal canal. Also, you can see the massive inflammation on the mesial aspect of the palatal root, which is a sign that the filling itself was not the cause, but maybe a trigger for the complaints that the patient had. Premolars are tricky, and for my treatment I always have a very close look to the radiograph. Also, I always extend the access cavity until right under the cusps and search for a second canal. Especially in lower premolars, that has given me the insight to be more as suspicious when it comes to them. But I'm babbling around here. Back to ultrasonics. So how can you uncover the canal entrances without to sacrifice too much of sound and time? Of course, with the help of ultrasound. As you can see in this example, 2 entrances, the buccal and the palatal canal, are already discovered. So is this a reason to shout hooray already? A second canal in an upper premolar? No, certainly not, because we have seen the X-ray and there is more work to do. With an Endosonal file, which is a cutting file, remember that, you can specifically remove dentine in a very small localized area. With short strokes you can see that I was able to discover the distobuccal canal very easily and quickly. Now you can see the entrances that was covered by sound dentine. Without the X-ray I hadn't had any clue that there were a third canal, right? Here is it. Third canal, distobuccal. Now the master point X-ray shows the situation after the preparation with ProTaper files. In this case, it was necessary to do 2 eccentric radiographs to show all the canals. Also, the final result after obturation, I think that was an interesting case, not only regarding of the use of ultrasound. There is a small void in the final resin filling that was redone after I saw the X-ray. Now one can discuss if there is a need to crown that tooth. I would go for a crown, and that was my recommendation to the referrer. If this is already done yet, I can't say. Often you send the patients back, and it is difficult to get them back into the office for a recall, as you know. Another important use for ultrasonic is the removal of broken files. I have shown you a case a few minutes before, but this one is a more common case. Also, an endosonal file comes into the play again. The endosonal file is used here to create space between the canal wall and the fragment in order to loosen it. With short strokes of activation, I was able to loosen the fragment and it came out easily. But you always have to be aware not to make more damage to the dentine, as it is absolutely necessary. You can see how massive this file was and what power one have to deliver to such a big file to break it. It is sometimes a bit frustrating to see that some want to absolutely drill canals with absolutely improper instruments. If you have a closer look, you can see that the tip of the Endosonal file was broken also, while I tried to create space between the fragment and the canal wall. But it jumped out very quickly. Piezoelectric surgery is another great application for ultrasonics. This video was made by Leandro Pereira. Thanks to Leandro for providing me with it. For apicectomy, it is great to use. Minimal invasive cutting can be made with the help of special instruments or tips that are coated. Special tips that are angled in a special way are very good for removing canal filling materials from retrograde, as you can see here. Always use it with water cooling, and you can see it works great. And it is ready to be filled with MTA. Yes. The major application for ultrasound is the dissolve of vital or necrotic tissue in the canal. In this example, one can see it very clearly. The combination of sodium hypochlorite and ultrasound makes it to a very reliable method to remove any tissue. Here you can see a lower molar where the mesial canals confluent. There is a lot of necrotic tissue that has to be removed. With sodium hypochlorite, I began to irrigate the canal to rinse out the big parts of tissue. Then I used an uncoated ultrasonic tip because with this tips and ultrasonic you get a better cleaning effect than with irrigation alone. This is a Pro Ultra tip from Dentsply, the green one, as you can see. Now you can see how clean the canal is after the first irrigation with ultrasound application. Then the next irrigation sequence has started because there are still parts of necrotic tissue inside of the canal. So it's necessary to irrigate more than once, and now after some approaches in the same manner the canal is almost clean. But you also can see that there is a resorption of the root tips, and therefore you have to be extremely careful with the irrigation of sodium hypochlorite now to avoid any irrigation accidents that could lead to swelling and pain. That what you can see is periapical tissue that is necrotic as well. But you also can see that there is still a gap between the two canals that is filled with necrotic material. Here you can see it. Here maybe you can see the gap and the necrotic material which is inside of this gap between the two canals. With irrigation alone it cannot be removed. So I used the Endosonal Files again. I think you can see it very well. Here's necrotic tissue. Here's the gap. So, Endosonal File. Yes, I use it again to open the gap and to establish an access for proper irrigation. You can see that also here ultrasound is a big help to create space, very specifically to save as much sound dentine as possible. Again, a careful irrigation is important here. Very careful irrigation not to overpress any sodium hypochlorite over the apex. And now I have a properly cleaned canal that is ready for filling with MTA. Here you can see the cleaned gap, a very clean canal, and the open apex. This leads us to another opportunity to use ultrasound in endodontics, the compaction of MTA. Here we use the thixotropy phenomenon that we know when we make a plaster model. Also here we use vibration to make the plaster fluid in the same way it works with MTA. With your plugger you insert MTA into the canal and then you use your ultrasound scaler and deliver the energy to the handle of your plugger. And you can see what happens. The quite dry MTA becomes more fluid and you can easily compact it into the canal space. In this way you are sure that every corner of the canal is filled with MTA properly. Now you can see how fluid the MTA becomes when you apply the ultrasound energy of your scaler. The most disadvantage of this technique is that you have less control over it, especially when you have a wide open apex. So it is possible that you push MTA over the neo apex. Is it a real problem? I don't think so, but it can be avoided. It is better, I think. Now I'm at the end of my webinar and I have to say thank you to you all for your attention. I have to say thank you to Ru for the invitation to make this webinar. And I hope you found this webinar a little bit helpful for your daily treatment. And I hope we see us next time. Bye-bye.